it's a few minutes past 4. So we're going to start the second day of our conference, which is the 2021 Iraqi Anesthesia Conference, organized by the United Iraqi Medical Association UK and Ireland, in collaboration with the Iraqi Society of Anesthesia and Intensive Care. It's our pleasure to have you all today. There's a couple of points which I need to remind you, please. Can I ask you all to complete the form by following the link that's going to be available on the chat? It's available now. No has published it. That will take you to the feedback form, and through that feedback, we'll have your email, and we'll be able to provide you with the certificate of attendance.
مؤيد حط اللينك على فيسبوك همين الله يخليك
ان شاء الله.
لانه هذا الشات يختفي ورا من نطلع من هنا.
Yes, indeed. The other points that can I ask all attendees to make sure their microphone is muted, and if you don't need, then probably if you stop the video, we'll have a better audio as well. Now today we'll go and start with our first speaker. Our first speaker is Dr. Khalil Ahmed. Dr. Khalil is a graduate of Mosul College of Medicine from Mosul University, 1993. He's a consultant in anesthesia and a consultant in perioperative medicine. He's a fellow of the Royal College of Anesthetics in the United Kingdom. And he's been interested in perioperative medicine for some time now at parts in London. And he's going to speak to us about perioperative or preoperative anemia. Dr. Khalil, the platform is yours.
Thank you very much, Moyed. Is it okay, Moyed?
We haven't seen your presentation yet. No, can you allow share screen, please?
Yes, you're able to share screen.
Yeah.
I start sharing. Is my screen shared now?
Not yet, Khalil.
I shared it already from my side. Let me just.
Can we try again?
خلي أجيك مرة ثانية دقيقة. هسه؟
Yeah, excellent.
All right.
Yeah. Khalil, before we start, just one point. Can I ask all to write their questions in the chat facility, please? Write your questions in the chat facilities, please. Thank you.
All right. So, Moyed, again, thank you very much for you and Rafid for asking me to present in this amazing conference, which just happened a few days ago, actually, as someone has pulled out of it. So, but it was, if I wanted to present something, it would be anemia, definitely, because I spent the last of my 7 years running a clinic for anemia in BARTS, specially designed for preoperative assessments. And I'm going to talk about it today. And if you don't stop me, I can still talking for another 5 days about it. It's nearly half of my career I spend on it. So before we start, unfortunately, we are the worst country in the world, as Moyed know that, with the COVID. And we spend all the day looking like exactly this picture. I'm not doing any ITU at the moment, and I'm not doing that much NHS المستشفيات الحكومية. بس اللي يصير بالكوفيد بانديميك عندنا الكانسر كيسز بعد ما نقدر نسويها بالNHS most of the hospitals فنحولها على private نسويها هناك. I can spend good 12 hours a day just look like that. من تيجي الصبح تكون عندك طاقة جيدة you can do that for 3 hours. But after 3 hours, the virus becomes more friendly than the mask. ورا ما تنزع الماسك خشمك يصير double the size definitely, which is a problem. أنا عادة خشمي مثل الفستقة بس ورا الماسك تقلب الوجه. Some of my colleagues, they had even had marks permanent on their face because of the mask and how tight it is. So we are not enjoying our life, but it's a great challenge. So we talk about anemia, and anemia is why it is important and how common it is, and do we need to treat. Basically, WHO, they come up with figures as 30% of the preoperative assessment patients for non-cardiac surgeries are anemic. اللي هو هذا very high number. And if you know that my clinics in Baths, we receive about 35,000 patients a year. 9 to 10,000 are anemic. So it's a huge resources needed to treat these people, whether we need to treat or not. That's what we are going to see. Studies all over the world from North America and Europe, and now we can say UK and Europe because we come out of them, they say that 30 days mortality or morbidity with anemic patient is statistically and clinically significant. That means people with anemia will do worse than those who are not anemic. And this is quite obvious. Anemia comes with other comorbidities, reduce your functional capacity, and it will impede the speed of recovery. One of the most respectable journals of arthroplasty in UK, just recently, in May 2020, they chosen a study particularly looking at total knee replacements. And the reason they looked at total knee replacements is to come out of the blood loss intraoperatively by applying the tourniquet for these patients. And they just run the study to see, is anemia going to affect the recovery of these patients? And for sure, all the data came out of this study showing that anemic patients, they will have more length of stay. I mean, يكون بالمستشفى أكثر by roughly by 1 day extra to 1.3 day extra. And this is money in the West. Other than that, the rate of complication, healing, physiotherapy, full recovery from the operation were in much better figures for those who are non-anemic than anemic. The wound healing, the bone healing, the resumption of physical capacity, all were in favor of those who are non-anemic than those who are anemic, even for the milder degree. And this is very important when we say milder degree, because sometimes we lower the threshold by saying, okay, they are just mild anemic, and let us accept those categories still will actually suffer the unspeedy recovery. And why that is important, and we will talk about that later, because there is in the West medical legal issues as well associated with the problem. You have to inform the patient that they are going into which limb. Are they normal for the operation, or because they are anemic, they will actually may suffer extra rate of problems during theater. So the consent should be informed. دراسة أخرى جتي من North America, very respectable study. And هاي إنه بداية التسعينات, people start talking about giving blood is not good. And especially for the colorectal cancer and the breast cancer. And they found quite few studies. Giving blood for colorectal cancers is associated with actually higher rate of recurrence. As نوفل البارحة حكى إنه natural killers are associated with using of general anesthesia, and that's true. The blood همينة will cause immunological problems and reduce the immunity and can cause actually higher rate of recurrence. بس الستدي بداية التسعينات كانت non-conclusive and individualized. اللي صار هذا الستدي اللي هم 2018 طلعت very respectable study meta analysis, شافوا راحوا على كل الستديز اللي صارت بين 2004 إلى 2012 4000 مريض, and they saw the blood transfusion and the effect of that. اللي طلعوا به few points. أولا, very important, yes, giving blood for colorectal cancers is associated with A, poor prognosis, B, high rate of recurrence. But the poor prognosis, they justified it by saying, if you need blood, that means you are in bad situation anyway. Is either انت جاي too late you got lots of comorbidity, or surgically challenging that needed the blood. That's what they found actually at the same time. The amount of worse prognosis is proportionally associated with the number of units of blood. That means اللي أخذ 1 unit of blood has got much better prognosis اللي دام أخذ 4 units of blood. من جوي قالوا, how can we differentiate that between the blood and the comorbidities of the patient? لأنه logically, if you are more anemic, that means you're more advanced in the cancer, you've taken chemotherapy, you have more comorbidities. بس حتى write statistical tools to identify giving a blood is an independent factor associated with higher rate of recurrence and poorer prognosis. So blood is not great in some cases. My clinic, we see different types of anemia. But when I say different types of anemia, I need to focus on the most common one and the most easier to treat, which is the iron deficiency anemia, which comes into the category of hypochromic macrocytic anemia. So in this category, we have only 2 types of anemia, which is, A is simpler to put it in that category. We're only iron deficiency or thalassemia, but they are difficult to differentiate between them. And each of them has got total different type of treatment. And I'll explain why. While iron deficiency, انت ما عندك iron, they يروح لل DNA in the bone marrow to form RBC. While in thalassemia, انت عندك iron احتمال او احتمال ما عندك, لكن عندك genetic problem of producing alpha or beta chain of the hemoglobin. So iron is not the treatment of thalassemia, while iron is the treatment of the iron deficiency anemia. And it's very important, لأنه إذا يجيك واحد وانت you haven't decided this is thalassemia or iron deficiency, and we go to the treatment with iron, thalassemia patients, this is not in their best interest. The WHO قبل differentiate between men and women. And the reason for that, because we all know that women, because of the monthly periods and the vaginal loss, they are more prone to have lower hemoglobin threshold and defined as anemic if they are having hemoglobin of 120 grams per liter or lower. While men, they accepted 130 and above. But recently, 2 years ago, WHO decided حقوق المرأة paramount and decided 130 is actually universal for both sexes. That didn't help us at all. That makes more patients anemic now because it's very hard to find a woman with above 130 a gram per liter. So we have now more women defined as anemic by the WHO. In community, still iron deficiency is the most common type. And this is either due to the excessive blood loss, women vaginally and men mainly from the GIT, or GIT include stomach or hemorrhoids, or, but others counts for. But what we are here for is what we see the most. And in my statistics in my clinic, تقريبا 80 to 85% of my anemic patients are iron deficiency, and most of them can be actually due to the dietary deficiencies. Another classification of anemia, which is, I don't find it useful, is hyporegenerative or regenerative. Most of them are hyporegenerative. بس من يجينا المريض وندي investigations is very easy. I'm going to, Moayed, I'm going to increase the size. Tell me if you can see it easier now.
Yeah, thank you. Thank you.
All right, good. So, من يجي المريض undefined as anemic hair, whether it's 130 or 120, and I will be honest, we don't consider 120 as anemic. The threshold is 120, mainly in UK, not 130. But the first thing, POA, pre-operative assessment clinics, they are run by nurses, not doctors. Only those who need doctor to look at will be referred further, either for notes review, that means I just come here to the clinic and the nurses will give me a list of patients I have to look at the results or their concerns written on a note, or actually I see the patient face-to-face depending on the comorbidity of the patient. But when a nurse تشوف hemoglobin is lower than 120, not 130, immediately they run extra test, which is the iron study test. And this iron study test will include serum ferritin, which is here, and TSATs, which is in some labs they call it TIBC. TSATs is the transferrin saturation or transferrin bound capacity. And they run as well folic acid or serum folate, CRP, and serum iron. And from these tests, we can go immediately and decide what type of anemia is that and what treatment is needed. Very simple. روح على الفيرتين first of all, and if the ferritin is lower than 30, it is definite definition of iron deficiency anemia. But it is not that easy. لأنه, as you know, in UK we got primary healthcare, which is the GPs, and they can discover quite early that patient is anemic and they start patient on oral iron. And that's why the ferritin can sometimes, ferritin, by the way, reflects the iron store in your body. So it can have enough store, but not enough to regenerate. So enough just to keep the ongoing loss. So you may have normal ferritin, and you are still actually misdiagnosed of iron deficiency. And the one I look after, ferritin, is actually the TSATs, which is very important. The TSATs, if it is above 20% and the serum iron is low, this is another definition of iron deficiency anemia, and they will benefit from iron. But something which we not familiar with, but it is common, something called pseudoanemia, or actually functional iron deficiency anemia. The functional iron deficiency anemia is actually you take oral iron, but your gut doesn't absorb the oral iron, and this is because of an inflammation happening, okay? And there is hepcidin coming onto your body. And the way to find it is by running CRP. And that's why we run CRP with anemic patients, to see if this is, especially after we know the ferritin is normal, we go immediately and do the CRP to see if he's got functional iron deficiency anemia. I'm not going to talk about the other types of anemia. They are more complicated and need more treatment. I'm going to talk about the most common type of anemia and how to treat it, and the pathway for it, as this is what you see in a preoperative assessments. One of the things, forget about this slide. I will make only 2 points of it. As I said, it is very important to differentiate between iron deficiency and thalassemia. There is a test which called RDW percentage, which is actually red cell diameter width variation. أنا هشرح لك بشكل بسيط. من عندك ثلاسيميا، أنت عندك iron يجي، عندك genetic defect، راح تطلع alpha or beta thalassemia chain للهيموغلوبين. All the red cells will be equally small. Okay? While in iron deficiency anemia, any iron يوصل للبون مارو يطلع لك RBC. المشكلة الدفعة الأولى جتي for example 100 iron يطلع لك RBCs على 100. الدفعة الثانية جتي 80 يطلع لك أصغر RBC. الدفعة الثالثة جتي 120 طلع أكبر. ولهذا من يشوفون تحت الميكروسكوب they measure the largest RBC and the smallest RBC, and they make the difference into percentage mathematically. So either red cell width variation more than 15%, this is another way to know that this is iron deficiency anemia, and you start immediately on iron. I wish this is clear. Again, reticulocyte is important to just decide whether they're hyporegenerative or regenerative, but that doesn't make any difference. In this slide, I just want to make sure that we don't forget the MCV. The MCV will decide which type of anemia we're talking about, macrocytic or microcytic. And more importantly, the megaloblastic anemia or the macrocytic anemia happens with another diseases. I said about that earlier, which is sometimes it's difficult to differentiate, but these are the main things to decide if this is iron deficiency anemia. Let us talk about more boring stuff. We found that 20% of our elective hip and knee replacements in the UK are actually already anemic, which is a what? I mean, if you know that my hospital, we do about 4,000 to 5,000 hips and knees every year. That means 1,000 patients of these are anemic, which will delay the surgery. and 25% of those were already diagnosed with hypochromic microcytic anemias. In emergency circumstances, the percentage is even much, much higher, and you don't have time to treat. Like in the neck of femur, we found that up to 45% of our patients were actually anemic. And I will consider this figure is really underestimated, as I never seen neck of femur for a long time who is not anemic. So what's the consequence? I mean, after all that, why it is important? Evidence-based medicine, we talk here. We've shown that it associates with increased preoperative morbidity and mortality, increased length of stay, poorer functioning in survivals. Of course, there will be more incidents of they have to give blood, all the adverse effects of giving blood. And more importantly, morally, legally, and as a care for the patients, anemia is a treatable cause. And if you receive a patient here in UK who is anemic and you ignore that fact, you may be liable for a court case. For two reasons: patient is not being informed, and you deny the patient of treatment. Especially, I mean, if you talk about gynae, and you didn't refer the patient back to GP to refer to the gynae to see if they got cancer, endometrial cancers, or the men and other issues. So it can be actually challenging ignoring a fact that this patient is anemic and you ignored it. هسه الكل قالوا شو بسطنا نضبط لنا نفضها. So when we start to treat, the aim مالتنا is to reduce the chance of developing anemia and to treat the cause. But other questions we ask ourselves, and we continue to ask, there is no clear answer. شو وقت نعطي blood? And a story of every arthroplasty, every hip replacement, and knee replacements, that means either tourniquet or non-tourniquet cases, they will lose 3 grams of hemoglobin. Hip, they lose it in theater, and knees, they lose it next day. So some people say, okay, I will do the knee because actually they will be tourniqueted. Doesn't work like that. They will still lose 3 grams of blood. And يجي السؤال إنه then what is the hemoglobin level to accept? In UK, we accept 12 without the differentiation between men and women. But the pillars of our management actually is, first of all, before the operation, is to optimize the hematopoiesis. And what does that mean? That you run the studies and then you find that the folic acid is low. You start treating it. You don't say, okay, I'll take the patient to theater. You start replacing the deficiencies, the iron stores. Try to increase the patient's own blood. At the same time, you minimize blood loss and bleeding. Patients on chronic use of non-steroidal, especially the arthroplasty patients who are by definition chronic neuropathic pain cases as well. Many of them actually on non-steroidals. Many of them, they are old age and on another medicines that can cause extra bleeding, like aspirin. We don't stop aspirin now, but they can be on dual antiplatelet therapy, and all that should be looked at to minimize the blood loss and bleeding and improve the patient physiological tolerance to that anemia. What I want to say from the slide is anemia in UK is a multidisciplinary team approach. I work on it as an anesthetist, surgeon work on it as the surgeon, hematologist, labs, nurses, and post-operative wards. They all work on it. It's not one-man job to decide or to deliver the care. We talked about this slide before, but one thing I want to emphasize here, it should be investigated. Many POA clinics in UK, they don't accept the patients and refer back to GP for further investigations. What I learned from UK is, and دائما أقولها راح أظل أقولها, in UK I صار لي 20 years ما شفت genius doctors, بس شفت genius system. That means you rely on the organization to deliver the care, not on individuals. That's why in UK the NICE guidelines come out of it, all the protocols, which means that المريض اللي عايش في قرية في شمال اسكتلندا راح ياخذ نفس العلاج اللي مريض قاعد ياخذ العلاج in tertiary center in central London. That's because of the protocols. And it should be done within guidelines. Every place should do the same. The organization, they benefit you in establishing treatments like IV iron. And this is the main topic I'm talking about now, the importance of the IV iron. The hematologist only referral happens on only more complex cases like the sickle cell diseases and the complex sicklers. More importantly, IV iron, إذا نجي على 10 سنين قبل, they were restrictive to hematologists. I am one of the first clinics in UK who developed IV iron therapy with my own ward. عندي يوم الاثنين عندي one ambulatory unit which is about 15 beds. المريض يجي الصبح ياخذ IV iron ورا ساعة يرجع البيت أو ساعتين after we make sure that he didn't suffer any complications. It's very easy, very cheap. We still can make money out of it. And it's very useful. Because if you put the IV iron in the hands of the hematologist alone, which they won't actually, but they don't have the capacity. I'm talking about I treat with IV iron roughly about 1,000 to 2,000 patients a year. هم already عندهم full list. When I send to them, I used to wait for a couple of months for IV iron dose. After I open my own clinic and open my own ward 1 day a week, all these patients I see the week before come on Monday, have the IV iron and go home, and I check on them in 3-4 weeks' time. Cortez et al., hematologist, he decided that actually with his studies and his colleagues that IV iron is much better than oral route. For many reasons. They are more expensive though. Oral route not always tolerated and it is or absorbed. Not tolerated, it causes constipation, tummy upsets, patient compliance, or if the patient has got pseudo iron deficiency anemia or functional iron deficiency anemia, they will not benefit from it. It's not going to their blood. And the time it takes oral to improve your hemoglobin is much, much slower than IV iron. IV iron start improving hemoglobin within 2 weeks. In 4 weeks, it improves quite a lot. And there is a formula. There are mainly 2 types of IV iron in UK and Europe, which is the Ferinject and the Monofer. And Ferinject is very, very, very promising, less side effects, less anaphylaxis rate, and much better tolerated by the patients. Third line, after that fails, we may consider actually erythropoietin. And we'll talk about erythropoietin later. I'm going to escape that one. Apart from, after you run the functional iron deficiency anemia, you consider IV iron immediately, not the oral because it will not be absorbed. But when we run the studies of the folate and the B12, it will come up with actually if they are normal and the hemoglobin is normal, we know that we may consider erythropoietin. Blood transfusion only indicated actually when the blood loss is expected to be higher than 500 mils or 1 liter. We are coming to the end of the presentations about the erythropoietin. It's very expensive. It needs funding. Usually the renal units, they have it. I mean, most of the end-stage renal failure 4 or 4 plus A to 5, actually they are on erythropoietin to improve their hemoglobin, as it's mainly manufactured by the kidney, and which is not working anymore, and they need it to start producing their own hemoglobin. As I said, it's expensive, but it's been used. We use it in a few cases during the year, and I can remember the main 3 reasons I used it last year is, A, I have a patient who's Jehovah's Witness. That means they don't accept blood, so I improve the hemoglobin up to 18 grams per liter by giving them erythropoietins. Those with rare antibodies, that means it's very difficult to find blood compatible to them. So the best thing is to improve their hemoglobin and you can do the autologous transfusion later. So you improve the hemoglobin, you take their own blood, and you give it back to them later if they need it. And people who are actually in a chronic renal disease. But with erythropoietin, we have to remember that we still have to give iron, because what it works, it will actually improve your RBC production, which need resources, which is the iron, the B12, folate to produce. And we have to have hospital policy for it. It's expensive and it doesn't come just over the counter. Conclusion to come up with, I hope I'm good with time. 30% of preoperative patients likely to be anemic, with higher percentage due to iron deficiencies, easy and safe to treat. And then I've shown you earlier that evidence-based medicine, good evidence that anemia is associated with poorer outcome. But more importantly, actually, it's a treatable cause and you have to treat it. When we talk about erythropoietin, it's only for selective case only. Again, a blood transfusion is individualized. And one of the recent study I looked at actually shown that normalizing hemoglobin by blood transfusion is not going to associate the patient with lower mortality and morbidity. So the study is, I think it's conducted in about 2016, is not new anymore, but is actually shown clearly just giving the blood, like the patient come to you with hemoglobin of 7 and you give him blood in theater, that will not help. That will not. It needs at least 7 to 14 days to normalize the function of the oxygen delivery and the parameters in your body to set it up into another level of basic metabolic rate to get benefit from it. And it's not going to help when you just give it in theater. فأنا هذا راح يجي على آخر سلايد على حسبتك نقعد بنشتغل كل شيء والبرايفت شلون. هذا very important. And in UK, the beauty of UK actually is you take the same decision. You can't take different decision whether they are private or حكومي. That is not defendable. So the protocols comes into both places the same way. And the reason for that actually is شهادتك أو تسجيلك بالنقابة إذا مريض اشتكى عليك إنه ويشوفون إنه your private decision was on your interest لأنه عندك private تعطي فلوس من وراه. لو كان NHS كان أخذت غير قرار, this is قرار definitely you will come out of the GMC and you lose your job. I think at this stage I will be more than happy to take any questions.
Excellent. Dr. Khalil, many thanks. You are just exactly with the time and very pleasant and excellent presentation. We learn a lot actually. I just want to reiterate your comment that there is no more genius doctors, rather a genius system. Exactly. We have a system that works very well for all people and all doctors. Dr. Khalil, just one question I have, if you, well, a couple of questions basically.
بس لا تقول لي على حسبتك نقعد ما نشتغل.
First question is that we do, I'm sure you do as well, cancer patients, and yeah. there's a limited time scale for those patients. Now, how do you approach that? Do you prioritize these patients or?
Yeah. Okay. What I presented is elective only.
Yeah.
There is another 2 categories. You know, on the CPO, there are 5 categories when to operate. The cancer patient are 2 weeks path.
Yeah.
You have no time to actually optimize. And there is another fact. In the breast cancers and the colorectal, it is not on the best interest of the patient to give blood. And I'll tell you why. We're already on chemotherapy to reduce the amount of the tumor. And the reason we start this MDT approach for cancers is to make the tumor regress in its size before surgical resection takes place. Giving more hemoglobin for cancer patient has shown it will impede the regression of the size. لأنه the tumor is well fed. So anemic patients with cancer is a beneficial, not a disadvantage. Whether you want to give intraoperatively to keep the patient alive, this is different issue. بس إذا تيجي على cancer patient, they will accept hemoglobin intraoperatively of 7 if the patient is okay. When you talk about patients who are, for example, arthroplasty or another type of operation, they will come with a threshold up to 10. But especially the cancer patient, and especially breast and colorectal, they will accept much lower hemoglobin before the operation because it will help them resect more tumor.
But Khalil, do you still give them IV iron or no?
If they are iron deficiency, yes.
Okay, that's fine. The other question, which I may ask, if you don't mind, if a colleague from Iraq wanted to set up a preoperative IV iron surface, what are the elements required in your experience to make this clinic successful?
As I said, multidisciplinary approach is the vital part for it. But we know different countries, they got different approaches. One thing is, you know, the slide which I shown about how to take the patient from hemoglobin low into what type of anemia they are. Hold a sec, I'll show it to you again. Let me share again screen. Screen shared?
No, can you allow screen share for Dr. Khalil?
It's enabled now.
Okay, available.
All right. So إذا أروح لك على هذا السلايد, which I think is the most important slide actually of all.
Yeah.
This one. راح أكبر لك إياه دقيقة. Moyed, look, if they want to start a pathway, this is the pathway.
Yeah.
And if we take about, we go from here up to here. All right. So I think this is the most important thing. هم anemic or not? If not, if anemic, then actually these tests must be done to know what treatment they are. And حقيقة من WHO يقول لك 30% anemic and then 30% of that are iron deficiency. In POA is not that true. In POA, the majority are iron deficiency. I mean, to be honest with you, sickle cell in Iraq, I never seen it when I was there. But thalassemia, yes, you can. And in Iraq, you may find higher percentage of pernicious anemia or megaloblastic anemia, chronic anemia of chronic disease because of thyroid. But these three tests are your main pathway guidelines. And from here, you can decide whether this is IV iron or not. If the ferritin is lower than 30, this is definitely an indication. People may say, I want to give oral iron and C. Fine, it works sometimes, it takes time. خاصة إذا تعرف بالعراق ما POA between POA and TCI is short period of time. لأنه السيرفيس بالعراق is not only mainly private. المريض يجيك الاثنين by another 3-4 days should be on the operative table. And to be honest with you, Muayyad, neither will work.
Yeah.
But in UK, when you say that the patient is not fit to come in 1 month's time, it's a different story.
True. Yeah. There's one question from the platform from attendees. What's the onset of action of IV iron to correct anemia preoperatively?
There is 2 elements, Muayyad. أولا, إنه why it is anemic. خلينا نحكي, for example, gynae people.
Yeah.
They bleed a lot. The amount of you replacing is far less than the amount they lose. And at stage, you have to operate. You can't keep losing without replacing. But in a normal patient with dietary deficiencies, anemia, 1 month is enough to push the hemoglobin by another 3 grams.
Okay. Dr. Khalil, many thanks. And thank you again for this pleasant and excellent presentation. And I'm sure we're going to have you again in future conferences and meetings. Thank you very much.
بس اعطيني وقت احضر احسن شوي.
لا, it was a very good one.
Thank you very much.
Dr. Ali is going to present the next trainee speakers. Dr. Ali is yours. Dr. Ali, are you there?
اي اوكي السلام عليكم.
عليكم السلام.
اوكي سمعوني؟
نعم تفضل.
اوكي next speaker is واحدة من اهتمام الجمعية انه نهتم اطباء البورد والدراسات والاطباء الخريجين الجدد من اجل طبعا التعاون ويا المجالس العلميه من اجل تشجيعهم ومن اجل ايضا انه تبادل الخبرات لزياده طبعا تقديم احسن الخدمات بالعراق. وطبعا ما يخفى على ذلك انه التنسيق مع المجالس العلميه وهمها مثلا المجلس العلمي للتخدير اللي كان سباقين للتعاون، وايضا انه بنيه الجمعيه تنظيم مسابقه لطلاب البورد من مختلف الاختصاصات لافضل طبعا برزنتيشن وبوستر برزنتيشن ان شاء الله في المؤتمرات القادمه. Next speaker is Dr. Mohammed Wahab. Dr. Mohammed Wahab is Iraqi board trainee and he's going to give us a talk about anesthesia is not guilt.
السلام عليكم.
عليكم السلام دكتور محمد.
Can you hear me please?
Yes, we can hear you.
I share the screen now.
Excellent, well done.
Assalamu alaikum. Good evening everybody. First, I would like to thank United Iraqi Medical Association and my prof, Dr. Ayad Abbas, for this nice opportunity, and I'm glad to share this information with you. First, this map is from World Federation Society of Anesthesia, which is published from 2017. It shows the shortage of medical resource in healthcare. The yellow and orange area shows significant deficiencies in the healthcare. As we know, the anesthesia is a part of that healthcare system, so the anesthesia is suffer from that shortage too. The crisis events intraoperatively in anesthesia is happening frequently in these areas because of indulgence or lack of protocols. This is the first. Lack of access to essential drugs and equipments, which play a critical role in patient lives. These factors are collectively affected the outcome of the anesthesia and the surgery together. This is another maps. It's from the same source. It shows the density of the anesthesiologist, the number of the anesthesiologists per 100,000 population. The red and orange area shows significant depletion in the number of the anesthesiologists in the world. For example, of that shortage, in Ethiopia, there are only 23 qualified anesthesiologists for 90 million person, while in Rwanda, there are just 14 for 11 million person. While the most shocking number really I face is in Sierra Leone, there is only one anesthesiologist for 6 million person. In my opinion, it is not enough to provide these people with a qualified anesthesiologist. We must give them a good solid environment and a permanent access to drugs and equipments that will ensure the safety of their patients. So, in fact, in 2017, according to World Federation Society of the Anesthesiologists, which declared that 5 billion person in the world, which is approximately 2/3 of the world, waiting for safe anesthesia and surgery. For that reason, they raised their logo, safe anesthesia, safety for everybody today. So in case of lack protocol, resources, doctors, drugs, and equipment, of course, the blame here go toward the anesthesia because the anesthesia need high standards of safety. In this condition, safety is absent. So we must wait a little bit and not make a judgment, and let us imagine living without anesthesia. It means living with a painful, anxious, and life-threatening condition. Sometimes the human will face one of these accidental situations, which will lead him to face the surgeon and, of course, the anesthesiologist. At this time, some question will be asked to the anesthesiologist. Some concern and the question that may ask to the anesthesiologist is fear from death due to anesthesia, or fear from not recovered from anesthesia, and fear from feeling during the surgery, and fear from paralysis after the neuroaxial. We will discuss them there. Now, In 40s, the risk of death, it was 1 per 1,000. Then this number is decreased in 70s to 1 per 10,000. And by the 90s, it reached 1 death per 100,000. So nowadays, according to the World Health Organization, this number reached 1.1 per million per year. And this is not incomparable to the road traffic accidents in this area, which reached from 8.3 in high-income countries and to 27.5 in low-income countries. This is really not comparable. So the death from road traffic accidents is much, much more than the anesthesia. So we must realize the huge development that occur in the field. To be honest, not only the anesthesia, but also the surgery. So today we have, in addition to general anesthesia, more options that we had ever before, like neuroaxial spinal, epidural, or ultrasound-guided nerve block. All of these methods cause decreasing in a mortality rate. Now we will talk about the second concern, which is a fear from not recover from the anesthesia. Nowadays, the anesthetic drugs and the inhalational agent, which is way more safer than the old one, although they are not perfect, but really it's do better side effect profile and less systemic effect, which is totally enhance the recovery process. And the second concern, which is fear from feeling during the surgery. We must go in the history. Before 1987, if the anesthesiologist want to ensure oxygenating his patient, he will look either to his lips of the patient or hear his breathing and palpating his pulse, because the pulse oximeter was not available to the anesthesiologist in the operating room at that time. But basically today we found this, the oximeter in everybody's home. Today, the technology, as we know, improves everybody's life. So as anesthesia, like the ventilator, which almost everybody become familiar with it during the COVID-19. So all of these equipments helps us to avoid the problem of feeling during the surgery. Now we will take about subjects of paralysis after neuroaxial. Really, it's a myth. In 20s, anyone with apprenticeship can give anesthesia, like the surgeon or even the professional nurses, which makes the mistakes at their time. Until the 30s, the anesthesia residencies were established, and the residencies has undergo thousands hours of training and take rigorous board of exams to take care of patients. And these things developed to ASA guideline, which is based on data and evidence to optimize our work. So, to be honest, some complications sometimes just happen for unavoidable causes, like a patient with ASA class 4 or ASA class 5 who undergo emergency anesthesia. We expected really the complication. Or a patient with, he get pulmonary embolism, or due to genetic factor. This is not related to the anesthesia, like a malignant hyperthermia. Most of these irreversible causes occur accidentally, like a hurricane. So my message today is we must be more visible to the people. For the first time, we need to awake them, not sleeping them, for the incredible development in anesthesia for the last 60 years in the term of techniques, drugs, technology, monitorings, and certainly the huge training of the anesthesiologists. All these together makes the anesthesia more and more safe than before. And these faults is due to a factor not always related to anesthesia. At the end, I want from everybody who is worried from anesthesia to realize that we need to power ourselves with knowledge and fact instead of anxiety when we proceed with anesthesia. Thank you.
Thank you very much, Dr. Mohammed. Very interesting perspective of anesthesia, and it's how it's taken by people. Now, obviously, that is very much linked to our preoperative medicine and preoperative assessments. What do you think the information should be available for patients prior to anesthesia and surgery? and how you going to deliver these messages to our people?
I think the doctors must goes with protocols other than their knowledge or experience, which is better because it's related to the facts and knowledge, not the apprenticeship just. I think this goes out with a better result.
Excellent. Obviously, there are uh, many ways used to deliver the message of that's what you've been mentioned to the whole population, including the using of the media and the tools in the media, as well as we provide patients with some information in their preoperative assessment by leaflets. So explain the danger or the risks of general anesthesia, the benefits and the complications of regional anesthesia. This should be all available in the preoperative assessment clinic. Thank you very much. There's is there any more questions? There's no more questions here. Thank you, Dr. Hamad, and Dr. Ali is all.
Thanks a lot.
Thank you.
شكرا جزيلا دكتور محمد.
شكرا دكتور علي.
Okay, شكرا جزيلا دكتور محمد. A very nice presentation, and we are quite happy to have you today. Next speaker is Dr. Sundus Adnan Jawad, and also she is an Iraqi board trainee, and also she's going to give us another interesting talk about the opioid sparing anesthesia.
Thank you, Dr. Ali.
دكتورة سن أهلا بك.
Okay. Can you hear me?
Yes, carry on.
Okay. At first, I would like to thank the United Iraqi Medical Association in UK and Ireland for this opportunity to be part of this very nice and very useful conversation. My subject is about opioid-free anesthesia and opioid-sparing anesthesia. At first, the bariatric surgery. The increase in bariatric surgery procedure is due to numerous factors. First, the escalating of the rate of the obesity has led to more individuals seeking treatment. The prevalence of obesity in adult population is approximately 30% and has doubled since 1980. Bariatric surgery is an increasingly safe, effective, and simple procedure available in patients with BMI at least 40 who cannot lose weight via diet and exercise alone, as well as patients with BMI between 30 and 35 who have obesity-related health issues. The most important problem in those surgeries is associated past medical history of the patient, which may be morbid obesity, OSA, right ventricular hypertrophy, early onset coronary artery disease and systemic hypertension, adult onset DM, etc. Obesity is one of the greatest health challenge facing Western countries. Obesity is defined as body mass index more than 30 kg per square meter, whereas those with BMI more than 35 and 55 kg per square meter are considered morbidly obese and super morbidly obese, respectively. Approximately 5% of morbidly obese patients will have obstructive sleep apnea. In patients who give history of such as snoring, apneic period during sleep, and day-night somnolence should be considered for overnight polysomnography. This can define the type and severity of OSA. And also whether continuous positive airway pressure, CPAP, or bilevel positive airway pressure is required before operation. About obstructive sleep apnea is defined as cessation of airflow at the mouth and nose for at least 10 seconds, despite continuous ventilatory effort. 5 or more times per hour of sleep, associated with decrease in SpO2 of greater than 4%. What is the risk factor of obstructive sleep apnea? Stop-Bank questionnaire is a widely used Rafid tool to screen patients with obstructive sleep apnea. S for snoring, T for tired daytime hypersomnolence, O observation cessation of breathing during sleep, high blood pressure with or without treatment, and the body mass index more than 35 kg per square meter, neck circumference more than 40 centimeter, and the G is for gender, which is male, more in male than female. Analgesia for bariatric surgery. Today, the majority of bariatric surgical procedures are performed laparoscopically. Post-operative pain is not usually severe and is of short duration, typical a few days. Pain in this procedure is due to either surgical porthole, which is somatic pain, or polyneuropathy, carbonic acid deposited in parietal peritoneal, and from mild tugging on the gastroesophageal junction, referred visceral pain. The increased use of opioid in the perioperative period has increased the opioid-associated morbidity and mortality. There is a well-established connection between opioid and sleep disorder breathing and respiratory depression. The treatment of post-operative pain with opioid in patients with sleep disordered breathing may result in respiratory depression, which may need CPAP and BiPAP ventilation or even ICU admission. Challenges with opioid, adverse event, misuse, abuse, and long-term administration have led to renewed emphasis on opioid-sparing multimodal management for trauma pain. Opioid-free and opioid-sparing technique. About opioid-free anesthesia is a technique where there is no intraoperative systemic neuraxial or intracavitary opioid is administered. Perioperatively, opioid-free analgesia similarly avoid opioid in the post-operative period. A number of case reports and increasingly prospective study from all over the world support its benefit, especially in morbidly obese population, whether this patient have or without sleep apnea, obstructive sleep apnea. About opioid-sparing anesthesia, can mitigate the undesirable effect of opioid by facilitating the use of low effective dose of opioid. Multimodal regimen involve use the multiple medication, opioid and non-opioid with different mechanism of action, as well as non-pharmacological intervention to achieve more effective analgesia. Multimodal analgesic agent. The current cornerstone of minimizing opioid use in the perioperative setting is a multimodal analgesic regimen consisting of non-opioid pharmacological and regional anesthetic technique. Using this method, the analgesic can take advantage of the multiple mechanisms of different pharmacological agents that can act additive or synergistically to achieve the analgesia goal. The pharmacological agent, acetaminophen, which is the paracetamol, is the first one. IV acetaminophen has shown promising opioid-sparing effect and reduced the post-operative pain score as a part of multimodal pain regimen. It has been proposed that it has mechanism of action similar to non-steroidal anti-inflammatory drug, in that they inhibit the cyclooxygenase. Doses of acetaminophen 1 gram intraoperatively and then can reach 4 gram per 24 hours post-operatively. Non-steroidal anti-inflammatory drug, the most common two drugs that is used in the anesthetic practice include ketorolac and diclofenac, which can be administered IV or intramuscularly. Non-steroidal anti-inflammatory drugs act by inhibiting the enzyme cyclooxygenase, which ultimately result in a blockage of prostaglandin synthesis. Common cornerstone in terms of non-steroidal anti-inflammatory drug use in the perioperative period include gastrointestinal tract bleeding and platelet dysfunction and renal injury. Doses of diclofenac is 75 bolus IM pre or perioperatively, and the ketorolac 30 mg bolus IV or IM. Steroid like dexamethasone Synthetic adrenocortical steroid with high glucocorticoid activity. A meta-analysis examining the effect of perioperative dexamethasone on post-operative analgesia shows significant lower pain score and opioid-sparing effect at 2 to 24-hour and reduce post-operative post-anesthetic care unit stay. Dose of dexamethasone range from 8 to 60 milligram before operation. N-methyl D-aspartate antagonist. The first one is the ketamine. Ketamine is an N-methyl D-aspartate receptor antagonist. These receptor blockade result in decrease in nociceptive and inflammatory pain transmission. Dose intraoperatively can use IV of 0.5 to 1 milligram per kg as analgesic dose. The second one is magnesium sulfate. Magnesium has also shown an act on NMDA receptors antagonist. This property, in addition to its role as a calcium channel blocker, lead to its potential as an analgesic agent. Bolus doses ranging from 30 to 50 milligram per kg, followed by variable infusion at rate ranging from 8 to 50 milligram per kg per hour, post-operatively. Alpha-2 adrenoceptor antagonist اللي هي dexmedetomidine and clonidine. IV dexmedetomidine and oral clonidine has been shown to produce moderate decrease in pain intensity, increase the opioid-free time interval, and in the post-anesthetic care unit, and opioid-spare effect for up to 24-hour post-operatively. Act as at supraspinal, spinal, and peripheral side, causing membrane hyperpolarization and reduce calcium conductant into cell. Doses from 0.5 to 1 microgram per kg of dexmedetomidine bolus, followed by 0.2 to 0.4 microgram per kg per hour post-operatively. Clonidine orally 3 to 5 microgram per kg before or post-operative operation. Gabapentinoid, we have two drugs, pregabalin and gabapentin. They act on presynaptic calcium channel and inhibit neuronal calcium influx. Gabapentinoid may contribute to better post-operative pain management, enhance opioid tolerance, and prevent post-surgical pain. Doses 75 to 30 milligram of pregabalin orally pre or post-op, and according to gabapentin, we can give 300 milligram, and we can also reach to 1,200 milligram orally pre or post-operative. Parenteral local anesthetic, we have lidocaine, has analgesic, anti-inflammatory, and anti-hyperalgesic properties. IV lidocaine has been found useful in many types of surgery where the anesthetic and opioid requirement were significantly reduced. Doses, we can give bolus 100 milligram or 1.5 milligram per kg at least 30 minutes before incision, followed by infusion of 1.2 to 2 milligram per kg per hour intraoperatively, and then 1 milligram per kg per hour up to 24-hour post-operatively. IV lidocaine may prevent the development of continuous post-operative pain by inhibition of NMDA D-aspartate receptors. Regional anesthesia. Thoracic epidural can be performed for such surgeries with catheter for patient control, analgesia post-operatively. And according to the peripheral nerve block, has also been used as a component of multimodal analgesic for abdominal surgery. For example, transversus abdominis plan, which is tab block, rectal sheath block for more midline incision, thoracic paravertebral nerve block, and erector spine plane block, local anesthetic used for wound infiltration. As a summary, anesthesia for patients with risk of obstructive sleep apnea, like in bariatric surgery, can be conducted with opioid-free anesthesia or opioid-sparing anesthesia to decrease the expected associated morbidity and mortality. Thank you.
شكرا جزيلا دكتورة Sundus. It's a very nice talk and it's very interesting. Well, actually, even here in the UK, we do recommend that we take the ladder one by one, and we try to avoid heavy use of opioids. And you mentioned that very clearly, and we are very impressed with your presentation, as same as your colleague Mohammed. We have one question from Dr. Husham. Dr. Husham Shadar, he's a consultant anesthetist and consultant pain management in the UK. Thank you for your presentation. Do we use these opioid-sparing drugs in Iraq, like clonidine, ketamine, IV paracetamol? And also, I would like to add on top of that, are there any, do you put any parameters for monitoring for the post-op?
Yes, we use many of these drugs, opioid-free anesthesia in Iraq. Monitoring for post-op, unfortunately, only by monitoring the pain of the patient in the ward.
Okay, any more questions? Okay. دكتور نار. ايه حبيبي دكتور خليل تفضل.
Do you run sleep studies for all bariatric patients?
No, unfortunately.
So how did you decide these patients are asleep apnea? Because by definition, all bariatric will score 4 to 5 at least of a sleep study. And if you know the cutoff of a sleep stop is 3 and above, you have high risk of sleep apnea.
Yes.
So what
stop on your questionnaire 3 and above is have obstructive sleep apnea.
And you have to run the sleep study. شوفي opioid free anesthesia اجت من بلجيكا. They are mad about it. And they have evidence, they shown that even the stress response to surgery will be better without opioid. But what they use beta blockers, which is quite strange. So I feel that when the patient is tachycardic because of pain, you give beta blockers. I think that makes the anesthetist happy, not the patient happy. Right? One thing you may consider is the 1 gram paracetamol in bariatric, you can double it up to 2 grams in theater. So many people talking about, instead of 1 gram, I will give 2 grams. They are heavyweight anyway. And 1 dose is extra. It doesn't make that much difference. The ketamine is high dose, you put there. 0.5 to 1 milligram is high dose because we all know that.
I read many studies, sorry, doctor. I read many studies, they use a very low dose of ketamine, like 0.1 or 0.2, and it was quite enough.
Yeah. But 0.1 to 1, actually, we are approaching half of the anesthetic dose. لأن أنا شوفي إحنا من يجينا chronic pains not responding, and Dr. Shadar will agree on that. Sometimes they come to A&E, and the test to find that ketamine works or not is not more than 7.5, 10 milligrams of ketamine. And if it works, we put them on oral ketamine. I do a bit of bariatric. My observation is a sleep study for everyone. Because if they are on sleep apnea, especially if nocturnal central hypoapnea or severe obstructive sleep apnea, they are on higher risk and they should be initiated on CPAP before the operation, because whatever you do, you are coming out of anesthesia. And I don't know what gas do you use in Iraq. Sevoflurane is one of the worst gases, as they stay in the tissues for a long time than the new one, desflurane. And they come out of sleepy, and the concept of sleep apnea is not opiate. It is actually when they sleep, they don't breathe. So you have to keep them awake immediately. We use opiate in the UK. We don't use opiate sparing at all. The beautiful use of Fentanyl is available, which you come out of the operation needing less morphine at all. But we don't deny them of morphine. But the key effects of that is actually not to go over and let them sleep. You know what I mean? And it should be in a monitored area. The most important thing is monitored area where there is a nurse immediately available to see if there is a problem. Amazing presentation. Thank you very much, Sundus.
Thank you very much, Doctor.
I think we have more questions. You've been showered with question, Dr. Sundus, and I think Dr. Moyed راح تعطينا مجال لأنه we would love to encourage the trainees.
We have 5 minutes.
5 minutes?
Yeah.
Perfect. عندنا سؤال من دكتور ناهض المعموري اخصائي التخدير والعنايه المركزه يقول about xylocaine IV, is it a good analgesia and compared to opioid? And also we could mix another question from Dr. Zaid, and would you consider IV or infiltration of lidocaine, which is more efficient? Do you think is much better? Have you found out, or?
I mentioned xylocaine as one of many other drugs, just to avoid using the opioids. For me, it is better to avoid opioid in such surgeries. Xylocaine is a good analgesia, is a good IV, is a good analgesia to avoid the opioid, using of opioid.
Very good.
IV or
Actually,
infiltration, I think it is better, but is of small duration.
لا الحقيقة احنا نستخدم الاي في infusion and for post-op, but we would rather that patient should be monitored.
Infiltration infusion better.
Yeah. There is another question here that's about the mention of gabapentin and pregabalin. Is it a good painkiller? I don't know if you use it in Iraq. Actually, just to tell you the part of our current practice, that we do use it for the total hip and total knee replacement as a pre-op and regularly as a post-op, and it's very effective painkiller. It's not alternative to the others, but is the with the mixture with the paracetamol and non-steroidals. There is another question from Galaxy A30. Okay, about magnesium sulfate. Is it have analgesic effects on an receptor or potential drugs that act on receptors? ما فهمت السؤال.
ولا not.
Okay, is magnesium. So let's rephrase it. Is it?
I can answer that. Magnesium, neuronal cell membrane stabilizer. That means it reduces the impulses transferred back from the nociceptors from the pain site back to the brain. So it will slow the process of transferring the pain impulses by acting as calcium channel antagonist.
I can answer this as well. Can you hear me?
Yes, please, Hisham.
The main function of magnesium in pain management, it's to block the NMDA receptor. So imagine this is a receptor. Usually when other chemicals like glutamate substance, P stands for pain, contact this receptor, the NMDA will open. So what happened, this receptor usually blocked by magnesium. And you need a lot of chemicals to take off the magnesium and open the receptor. So this NMDA receptor, for example, ketamine is antagonist, so block it. But it's naturally blocked by magnesium. So this is how magnesium works, by blocking the NMDA receptor. And it's one of the good drugs to prevent the post-operative pain.
Good. I think we have enough time now, Ali.
Okay, شكرا جزيلا دكتورة سندس وشكرا لكل الترينيز. It's a good chance انه we encourage all the trainees to participate harder and harder. You are very, very fruitful and a good add to the conference. Thank you very much.
Thank you,
It's yours.
Ali.
Thank you, Dr.
Many thanks. Thank you all, and we are hoping in the society and the association to organize a competition for our trainees in Iraq, and hopefully it's going to be within the next few weeks. Now, our next speaker is Dr. Hisham Shadar. Hisham is and a graduate of Baghdad Medical School, and he's also a consultant in anesthesia, intensive care, chronic pain. He's a fellow of the Royal College of Anesthetics, and he's also a fellow of the Faculty of Pain. He's going to talk to us about perioperative management of chronic pain patients. Hisham, all yours.
Well, thank you very much. I'm just going to try to share. Is it sharing at all?
Not yet, Hisham.
1 second.
No, can you allow sharing, please?
Yes, it's enabled.
Yeah.
Confirm sharing. When you put on share screen, confirm the screen you want to share.
Screen recording. Yeah, I don't know. For some reason it's not. Okay, because I'm using the computer. Share virtual desktop. Sorry, 1 second. It's not going to work.
Okay, just 1 second. We
have,
Hisham, when you touch the share screen, there will be another screen comes out. Confirm it.
Yeah, I know, but it's the screen comes as different. It's saying desktop, whiteboard, iPhone.
Yeah. Go to desktop. Go to desktop.
Yeah, I am doing it, but it's not working. So
okay, we're going to do that through our computer.
I can log in with the other computer.
It's okay, Hisham. Just 1 second.
Yeah, you can put it for me, please. Yeah. Did you get the email?
Just 1 second.
Sorry for that.
That's okay.
It happens all the time.
I think this is because of the desktop, maybe. Anyway.
Yeah, no problem. No, can you allow me to share slides, please?
Yes, it's enabled, or I can share from my screen if you want.
Yeah, do you mind? Oh, actually, I'm sharing now. Just 1 second. So I'll follow with. Can you see my screen now?
Yeah.
Yes.
Okay. Just 1 second. Hisham, is that your presentation?
Yes. Yeah. Thank you very much.
Okay, just tell me to. Yeah.
Yeah. Okay. Perfect. So thank you very much for giving me the opportunity to present my work, and thank you very much for the organizers. So basically, it seems like today's theme is about perioperative, which is fantastic. And this part is, I'm just going to tell you more about how to manage pain, how to manage patient who comes to have surgery, and he's or have chronic pain, and that patient is already on high dose of strong opioid. So the purpose of this teaching, this presentation, basically we're going to give you a plan how to manage this patient, and also how to manage the post-operative pain. It's good Dr. Sindus did that presentation before that, because one of the treatment that you need to help patients who have chronic pain, in addition to the opioid, you need to give them the other drugs, the opioid sparing drugs. But actually this time is additional, not sparing the opioid. Next slide, please. So before I start, I want to go through the strong opioid I'm talking about and the way we use it. I'm sure most of you will know that, but it's nice to refresh you. So morphine is the most common drug we use. And remember, this drug has there are two types of morphine. One of them is immediate release morphine, and the other one is a controlled release morphine, or we call modified release morphine. So the modified release, basically, we give it usually twice a day because it's released gradually, and so it takes time to work, but it works for a long time. So to keep the level of morphine concentration at good level. However, a patient with the chronic pain, in addition to modified release morphine or controlled release, they might need something to give them a boost when they have breakthrough pain. And this is the immediate release morphine. So the immediate release, for example, Oromorph or Serratus, this drug works very quickly, within 15 to half an hour, but they don't last for a long time. Other drug we use as well as oxycodone. So the difference between these two drugs, so morphine is opioid, it's opiate. So basically it's a natural acting drug. It came from the poppy, from the flower itself. Oxycodone, it's like a man-made morphine. It's modified. So they took the poppy, they changed the chemical structure, and they came up with the drug which called oxycodone. One of the advantages of oxycodone, it has less side effect compared with morphine, and the bioavailability is very important. So bioavailability, so how much of the drug reaches systemic circulation after taking it orally. For example, morphine bioavailability is about 30, so 20 to 40%. So if I give you 10 milligram of oral morphine, actually only 3 milligram reach your systemic circulation, because the rest will go into the stomach and liver and metabolism and other things. While oxycodone, the bioavailability is about 80 to 90%. So if I give you 10 milligram of oxycodone, technically I'm giving you 9 milligram. I'm talking oral. Yeah, so it's a very good drug. So that's why it's half the dose of morphine, because it's like, it's not double strength, but the availability. Again, it comes as immediate release and controlled release. The immediate release, which work very quickly, it's called short-tech, from its name short, so short-tech. The controlled release or modified release is long-tech, because it lasts for a long time, or oxynome or oxycontin. So these are the two important drugs. Next slide, please. And other drug we use in, I'm talking about the UK, patient with a chronic pain. We don't usually like having them on opioid, but there are thousands of people, hundreds of thousands of people on opioid anyway. So you will be faced by one of them. Fentanyl patch, so it comes into different concentration, like 12, 25, 50. And so, for example, 12 microgram equivalent to about 45 to 50 of oral morphine. So it's a large dose. Hydromorphine is not used commonly. So there is, again, immediate release and controlled release. Next slide, please. And the other one is buprenorphine. It's commonly used in chronic pain. So you go to buprenorphine patch. So Butran, which is 5, 10, 20 microgram per hour dose. And there is larger dose, which is Transtec. And it comes as a tablet. So tablet is used for acute pain as well. So if you give 200 micrograms sublingually, they work very well. So this is for you guys if you want to consider it for treating patients who you struggle to deal with their pain. And there are other drugs which like Suboxone and Subutex. These mainly used for dependency, for addiction, basically. They have buprenorphine. One of them have buprenorphine and naloxone. So most common drug we see morphine, oxycodone, fentanyl, buprenorphine patch, and other drugs like we call them weak opioid, like codeine, dihydrocodeine, and tramadol. If they are large dose, you need to consider them. So next slide. So this is another important slide before I start, because if patients come to you having surgery, they are on strong opioid, okay? And if you stop their opioid, they might go into withdrawal symptoms. So this is very important to keep in your mind. The symptoms mild to severe, mild maybe just running nose, nausea, anxiety, to severe, they might get into severe spasm, dehydration, they go into panic attacks, they become very aggressive, and moderate, which is agitation, tachycardia, anxiety. So there are horrible symptoms. I've seen it a lot in patients when they come to A&E. Next slide, please. So what you do, so let's say you're running an anesthetic list for whatever reason. And we in the UK, we see the patient in the pre-operative assessment. I'm sure in most of countries as well. And this assessment clinic, pre-op assessment clinic, mainly run by nurses and a consultant anesthetist. So when you face with patients who have chronic pain or on opioid, you need to ask yourself 4 questions. Are they taking strong opioids? Do they have a chronic pain condition? And do they have bad experience with post-operative pain? And are they expecting to be in pain because the type of the surgery? If you answer yourself 2 out of these 4, most likely this patient will be challenging. So you need to flag up this. So what you need to do next slide, please. You need to make sure this patient is seen by a consultant anesthetist or wherever anesthetic trainee there with experience dealing with those patients. And it's better to involve the pain team as well. So what we started in our hospital, we started something called Transitional Pain Clinic. It's just recently. This is also, it's like pre-op assessment of people who taking opioid. I have a pain nurse with me, a pain physiotherapist, and pain psychologist. We go with the patient who have chronic pain taking medication, and we make a plan for them. So you don't need to have this clinic. So as a consultant anesthetist, you need to make a plan in advance. For example, you highlight this patient on chronic pain, make sure you have this medication, and the plan we're gonna go forward now. I'm gonna tell you how to do it. So it's important, communication is very important. So you put a plan from pre-op time, intra-op time, post-op time as well. Make sure they take their medication as well on the day. So, and patient education is very important. Those patients usually very anxious. So you need to tell them, you need to be reassured, your pain will be managed very well. Tell them you will expect some pain, but we will definitely help you with that pain, because psychologically it's very important to involve the patient and get them ready for that. Make sure they take their regular medication on the day of the surgery. Make sure if they are on patch, they continue using the patch. If they have intrathecal pump, they need to continue using the basal dose of intrathecal pump. The reason I made this guidelines, I had a lot of my anesthetic colleague asking me about when the patient comes to them. And one of the common questions, shall we stop the patch? Shall we take the patch off? No, please. Continue, the patch is very important. Next slide, please. Next slide. Moyed, next slide. Can you hear me?
Yeah, I can hear you. I don't know why I stopped working, but yeah.
Fantastic.
Sorry.
No, thank you. So this is like a risk stratification of patient coming with severe pain. It's just a quick slide. Just to tell you, this slide tell you, if we stop the opioid, this dose of opioid, what's most likely going to happen to the patient in terms of failure of analgesia and withdrawal symptom. So if the patient on low dose, we're talking here 24-hour dose. So for example, morphine 25 milligram twice a day. So if the morphine up to 50, oxycodone up to 25, small dose of fentanyl patch, buprenorphine up to 20, and other drugs there. Most like it's withdrawal symptom unlikely if you stop these drugs, okay? Or might be in the mild range, like you become sick, nauseous. So better not stop them. And the post-operative analgesia will fail. If they are on medium dose, so for example, morphine 50 to 150 milligram. So this is, I know it looks very large dose, but for those patients, they are not opioid naive. They've been on opioid for a long time. So this is a medium dose for them. If you stop it or decrease the dose significantly, okay, they most likely have withdrawal symptoms, and your pain relief most likely fails significantly. So please continue, do not discontinue, which we're gonna throw this as well. And of course, if patient on higher dose, they most likely have severe withdrawal symptoms, their pain definitely fell, especially one who taking large dose of morphine patch or the one who use methadone. So methadone is mainly for addiction, okay? So those patients, make sure they take the methadone, okay, and their buprenorphine. Otherwise, they will have significant withdrawal symptom, and your pain relief does not work. So remember, we all do anesthetic. We all can give propofol and small dose of fentanyl. But the most important, for me, part of anesthetic is the pain control as well. Yesterday, we were talking about the stress response, for example, which make a huge difference to the patient. Bleeding as well, we're talking about anemia. So if your pain is well controlled, okay, all these side effects will be less. So that's very important. Next slide, please. So what you do, let's say you faced with this patient. So you came in today to have a list, and one of the patients came to you who's taking strong opioid. So what shall I do? So first of all, you need to make sure how much they use opioid, okay? Why they're taking this opioid, okay? What kind of surgery they having now? What shall I do? So important to continue the drug, very important, don't stop the patch, okay? If they have intrathecal pump, continue the basic dose of the pump. And the other thing, remember those patients, they have high risk of regurgitation during induction. So treat them as full stomach, especially if they are on medium or high dose of opioid. Yeah, so 50 of morphine. You're most likely okay with it, but please remember that. If the high dose, treat them as full stomach. Next slide, please. So what we need to do, so again, we said continue. Remember, when patients have patch, for example, heat make the absorption of them, the patches increase. So for example, if you put a bear hugger, so it's a warming blanket, remember they might have higher dose. Remember, those patients need higher dose of morphine. So for example, if they're having any type of surgery, let's say knee surgery, and you decided to give 10 of morphine or 200 of fentanyl, they will need usually double the dose. Okay, so remember, give them more. And the adequate level of opioid is usually when the respiratory rate between 12 to 14, not like normal people 10 to 12. They might need higher respiratory rate. And the other thing is mild meiosis, which you can see in the eye. And this is what Dr. Sindus was talking about, important to use this medication. For me, in my practice, when I face with this patient, I will definitely give them 300 milligram gabapentin pre-op unless contraindicated. I give them the normal medication dose of opioid pre-op, intra-op paracetamol IV. So IV paracetamol, as Dr. Khalid saying, you can give 2 grams as well, okay? It's fine. I've done it many times with no problem, but you need to justify, because some people, they say, why did you give 2 grams, not 1 gram? So 1 gram of paracetamol IV, it's equivalent to 5 to 10 milligram of morphine. So imagine, it's a very good dose. Non-steroidal, very important. Ketamine. So the dose of ketamine, I usually, for those patients, I give them 40 to 50 milligram. I know it's a large dose, but it's nothing for them. Magnesium, it's about 2 to 4 grams. 2 grams is fine. Clonidine, about 50 to 100. Gabapentin, you talked, and lidocaine infusion. I love lidocaine infusion. You know, when someone asks about, does it work well or not? In my experience, works very well for acute pain and works very well for chronic pain as well. So what I give, the ampoule of 10 ml of 1%, this is 100 milligram, I'll give it within 10 minutes. So it's so the dose is 1.5 milligram per kg over 10 to 20 minutes as just a bolus dose. You can continue as infusion if you want, but of course the hospital need to be prepared for that because they need continuous monitoring. And don't forget regional anesthesia. If you have a chance to do regional anesthesia, please do it. So remember, this patient, for example, they came on opioid, they have back pain, okay, or neck pain. Okay, whatever type of pain. They came for knee surgery. I'm just keep giving the knee surgery example. When you do spinal or nerve block, this will help with the knee, but it's not going to help with the back. Maybe a little bit to start with the back, but when they wear off, they don't help with the back, or they don't help with the shoulder. So they need their medication. Okay, so at least people on you plan to do the surgery and the regional anesthesia, you should keep the basic level of morphine or opioid in general. Maybe give 50%, but not less than this. Next slide, please. So a plan, so then with the post-operative period time, of course, important you plan this in advance. Yeah, when I said, do you see the patient in pre-op assessment? Make a plan. So we prefer to have PCA. So those patients, even if they can't take orally, so if they take orally, make sure, we're gonna go through this in the coming slides, they have their oral normal dose. You need to give extra for acute pain, which they have now, but they need PCA as well. Okay, PCA works very well for them. Or regional anesthesia. Remember, so the basal dose of systemic opioid, even if regional anesthesia is used, keep them, don't stop them. And remember, need to keep eye on them because they are at high risk of opioid toxicity. Although they are on large dose of opioid, but they are the people who are high, they are high risk patient. Next slide, please. So, okay, we said that avoid withdrawal symptom. Remember, if the patient, you decided to stop their opioid for some reason, they might develop withdrawal symptom. In order to decrease these symptoms, you need at least 25% of the normal dose of opioid. Okay, remember to use the multimodal analgesia. Next slide, please. So I'm just going to go quickly. So pre-op, we gave the gabapentin or whatever, or the normal medication, continued the patch. Intra-op, in addition to anesthesia, we give analgesia, and we said paracetamol, non-steroidal, lidocaine infusion, ketamine, clonidine, whatever. Now the patient, the surgery has finished. Okay, now the patient coming to the recovery. So in the recovery, in the acute phase, we usually prescribe patient some analgesia, so maybe 1 to 10 milligram of morphine. Remember, they need 2 to 4 times the normal dose of opioid-naive person, although you give them plenty of analgesia. So please prescribe instead up to 10 milligram, maybe up to 20 milligram of morphine. Or fentanyl, up to 100, make it up to 200 microgram. Make sure you review them in the recovery and be aggressive with their medication. If you didn't give IV lidocaine, remember this is a good time to give it, like over 10 minutes in a pump, 100 milligram. And of course, you continue other drugs unless contraindicated. Next slide, please. And then start the PCA early. So before they leave theater, please prescribe the PCA for them. So this is important to understand. So if the patient can't take orally, okay, so they don't have surgery that affecting their eating and drinking, like big bowel surgery, please remember they need 1.5 times the pre-op dose. For example, they take 50 milligram of morphine, you need to give them 75, okay? And PCA for breakthrough. This will give them very nice analgesia and keep them comfortable. If the oral dose is unavailable, you need to give them their medication, which they use for chronic pain, as a background in the PCA. So the PCA can put background, okay, which I'm going to talk about morphine, how we do it quickly at the end of the presentation, which I need maybe another presentation to talk about all the drugs, but I'm just going to talk quickly about morphine. So you need the background for the chronic pain, and you need the PCA for the acute pain, in addition to other drugs, the opioid-sparing drugs. Yeah, is that clear? And remember the level of dependency. Those people, for example, in my hospital, if they need to have a background, not all the ward will take them. Those patients, they might need high dependency unit, or they need a special ward where they have monitored a good number of nursing staff. Next slide, please. So with the regional anesthesia, remember, they need to have their opioid, yeah? You're not going to just give regional anesthesia, you're not going to give them the opioid, because regional anesthesia will last maybe for a few hours if you do only block. So they need at least half of their pre-op opioid dose. So if they take 50 of morphine, they need 25 of their morphine, at least. If me, I put them on 50, the same dose. And the regional technique, okay? If the regional technique is only nerve block, you need to prescribe PCA for them afterward. You need to review them because the requirement will be increased in terms of opioid. However, if it's like epidural catheter infusion or peripheral nerve catheter infusion, which runs for 3 days, you stick with this, half dose of the normal requirement. They might need more, so they need a regular review. And remember, put a high potency opioid like fentanyl, okay, instead of morphine, maybe in the epidural. Ketamine is very important, don't forget about it. Orally, they might need it post-op. When we struggle with patients with those patients, they might need ketamine. So you just give them like 3 days of 10 to 20 milligrams, 3 to 4 times a day oral, just short course, okay? Tell them you might have some side effect. Monitor them is very important. So for opioid withdrawal, okay? As I said, the chronically opioid consuming patients are at high risk of respiratory depression. Next slide. Then you got the transitional phase. So patient left, went to recovery. We talked about recovery. Then they left, went to the ward. They need to be seen by a pain team every day if you have a pain team. So you need to tell them in advance. This is in the pre-op assessment. And then the transitional phase, this is where the pain gets better because the healing from the surgery has improved, let's say after 3 days. You need to calculate how much they had opioid in the last 24 to 48 hours. Let's say 24 hours in the PCA. Calculate it, give it half dose as a modified release morphine we talked about, and the other half as a short acting, so immediate release morphine every 2 to 4 hours. Yeah. I know this presentation is filled with information. It's a guideline, written guideline, so you can read it as well. So you don't need to remember all this, of course. It's all written. So if I face with this, what shall I do in the transitional phase? It's all written for you. Continue other drug, they might need paracetamol, non-steroidal, anti-inflammatory, or COX-2 inhibitors for 1 week, and then aim to decrease the dose of morphine to reach the original dose. And this is very important. That's what we do here. Those patients refer to me so I can see them in the pain clinic afterward. Make sure they're not having very large dose of opioid. Make sure their pain is well controlled. Yeah, so refer them, please. Next slide. I'm nearly there. I'm not going to take a long time. So this is quickly, so type of surgery. This is a quick guide for you, what you do. So if they come for day case or minor surgery, usually just maintain the usual dose of opioid. Don't go mad. Just take it easy. Usually local anesthetic, simple painkillers, and they go home. Next slide, please. If it is a major surgery, which we talked this early, and or emergency, but they can eat and drink afterward, remember they need 1.5 of the dose of morphine and the PCA. If they cannot take orally, remember change the PCA to background of morphine as well, in addition to the bolus dose. So you need bolus and you need background. And of course, regional anesthesia. Next slide. I think this is the last slide, so I'm nearly done. So this is important, how to change oral morphine to IV morphine. So remember, when you give morphine IV, the bioavailability is 100%. So all of it reaches your systemic circulation. However, if you give it orally, only about 30% reach your systemic circulation. So the IV dose is 1/3, okay, of the normal dose. So how do you calculate? Let's say you had a patient having big bowel surgery. He is on 120 milligrams of morphine per 24 hours, okay? So he cannot take oral, so we need to make it as a background. So you take 60 milligrams twice a day. In the 24 hours, this means 120 milligrams, okay? This is oral equivalent. So what you do, you calculate this as IV. So you divide it by 3. So 120 by 3 is 40 milligrams. So they need 40 milligrams of IV morphine in 24 hours. So this is 24 hours. We're calculating per hours, yeah? The background comes as per hour. So per hour, if you divide 40 milligrams per 24 hours, per hour, you got 1.6 milligrams per hour. So you can set the background as 1.5 or 1.6 milligrams. Remember, they need a bolus as well, and the bolus usually high dose. Usually we put 1 milligram. Those patients, they need at least 1.5, but I suggest 2 milligram bolus with 5-minute lockout. So they cannot have more than 2 milligram in 5 minutes as a bolus. Yeah, is that clear? Next slide. If they come as a patch, okay, and then they need PCA, all right? So you continue with the patch and they need PCA as a bolus. The bolus is 1 milligram, okay, 5-minute lockout. If they are a small dose of buprenorphine patch, 5, 10, or 20 microgram, just normal PCA. However, if they are at high dose, like 35 microgram and above, up to 70, they need 2 milligram bolus. The same with fentanyl. If it's 12 microgram per hour, it's fine, just normal PCA. If it's more than 12 microgram per hour, no, you need 2 milligram. So in general, I'm just going to conclude, you will face by those patients who have chronic pain who are taking strong dose of opioid. You need to make sure it's being seen by a specialist and the pre-op assessment clinic. You need to make sure involve the anesthetist who's doing this procedure on that day. Involve the pain team because the acute and the chronic pain team need to get involved. Make a plan for them. So tell them, okay, this patient, please ensure they continue on the pre-op medication. Give them gabapentin. Intra-op, make a plan for intra-op and make a plan for post-op. Okay, make sure involve the acute pain team so they review the patient and make sure those patients in the chronic pain clinic if possible. Next slide, please. I think I'm done. Thank you very much. If you have any questions, I'm more than happy to answer. I'm really sorry about the sharing. I don't know.
That's okay. It's okay, Hisham.
Good. Shukran jazilan, Hisham. It was very nice. A very nice talk. Any question? I think questions will come. Just I have a couple of things that as you mentioned, the Lidocaine infusion for post-op analgesia is getting more popular, and it's very effective, and we love it. Just a question from my side. Yes. Would you recommend, or what would you advise, fentanyl or morphine PCA for post-op, and why?
So basically, it doesn't matter, to be honest, if the patient on morphine, I'll continue on morphine, okay? However, if the IV morphine, it's causing side effect for them, I will go into fentanyl. But for the epidural, we recommend the patient to have a fentanyl instead, not only buprenorphine, so you add fentanyl as well. There's no preference. You can't start them off fentanyl, to be honest. Well, from my experience, they do well with morphine PCA. Usually,
yeah, because I asked this question.
Yeah.
I'm sorry, because I asked this question to pass a message to Iraq. So what is available is good.
Yeah, exactly. Morphine, oxycodone you can use as well. Fentanyl you can use. Make sure they are monitored. It's very important. Get some experience in it. Read a little bit about it. Watch a video how to prepare it.
Can I say something, Ali?
Yes, Khalil, please do.
Hisham, thanks very much. Very amazing presentation.
Pleasure.
One of the trickiest patients we deal with is acute and chronic pain. And this is very difficult for multi-factors, actually, which I found it pre-assessment is the first key stage of success by identifying them. And that's why actually where I work in my clinic, every erythroplasty patient will have the questionnaire immediately identified and to flag them up as soon as possible to the pain team. As you correctly said, it's not one-man job at all. I mean, you will be surprised to know that the main success relies on the ward and the pharmacist more than the anesthetist who saw the patient and will not see him next day. Because even if you put the plan, the pharmacist can come and says, I'm not comfortable in giving 200 milligrams of morphine because I don't want to lose my registration. And you have to have a very excellent communication as a team to deliver a successful plan. Now, what we've done now for 5 years is more than 5 years actually, we run the patient questionnaire. But what I want to ask you is, we have a huge success now with tapentadol. So what's your experience of it?
So tapentadol is very good drug. So this is another drug. So it's similar to tramadol. for people who doesn't know about tapentadol, it mainly inhibits the reuptake of noradrenaline. So it works for neuropathic pain. Okay, it works on the descending pathway, and it works as opioid. My experience with it is very successful drug. However, we don't use it massively in our area. We use it mainly for chronic pain, where people are really struggle to keep the pain relief on top. Those people who fail to respond to other opioid. And again, because it's a little bit expensive, the pharmacist do not have much experience with it. We start with the usual things like morphine and tramadol and other stuff. However, if they fail, we definitely prescribe tapentadol. Thank you for mentioning that. Thank you. Fantastic drug.
Yeah. Can I ask one question, Hisham?
Yes, of course.
Yeah. The question is that we do use a lot of intrathecal opioids like diamorphine and morphine. And how would you manage patients already on opioids when you plan to do intrathecal opioids in those patients?
So the dose, it's like 200 to 400 microgram or something. So it depends how much you give.
We usually use 1 milligram of diamorphine.
Okay, yeah. So you give a large dose, it's fine. Those patients, they are not opioid naive. They still need to take their medication normally. And remember, if you do only spinal for them, okay, the spinal will wear off. The dimorph will wear off maybe 5, 10, 12, maximum 24 hours, usually 12 hours. This is the time. They will need extra morphine. So this is the extra morphine that you are giving it to them. Okay, so let's say they are on 50 milligram of morphine or 100 of morphine. You give them dimorph or morphine intrathecally. After 12 hours, they're gonna need more morphine. So maybe you think about starting the new dose after 12 hours, after the morphine wear off. Very good question.
Yeah. Thank you.
I put it in my guideline. Very nice question. Thank you.
Okay,
Okay,
I
Mohit.
think. Thank you, Ali. Thank you, Hisham. That's great. Our next speaker is Dr. Wanj Khafaf. Wanj is a consultant in anesthesia and chronic pain at Prince Charles Hospital. He's a fellow of the Royal College of Anesthetics, as well as the fellow of the Faculty of Pain at the Royal College of Anesthetics. He's going to talk about management of pain management in fractured fractured patients. Wanj, are you there?
Yes, I am.
Thank you. Can you
Good
share your
afternoon,
slide?
everyone. Yeah, inshallah. Here we go. Can you see the slides okay?
All okay? Yeah.
Good. Masa al-khair, good afternoon, everyone. As Muayyad presented me, thank you very much for inviting me to talk here. I know it was a short notice, but I'm trying to do my best to talk about rib fractures. It was so far interesting talk, and I enjoyed listening to all of you. I'm going to talk about analgesia for rib fractures. Generally, we manage a lot of rib fractures. We are in part of Wales where we live in an area called, we have Bike Park Wales. There's a lot of bikers who comes and spend a lot of time there, and we have a lot of peoples coming with multiple injuries. At the same time, so we have a cohort of peoples who are elderly people who comes and they fall off from every sort of places and they injure themselves. So we have found that we needed to develop some sort of rib fractures pathway, and that's why I think there's some area that I've been interested in the last few years. It's, as you all know, that rib fracture is very common. It contributes to about 15,000 admissions UK and Wales, according to the Trauma Audit Regional Network. It's a big health burden. It's 1 in 5 patients who are admitted to trauma will have at least one rib fracture. And usually mortality that's directly correlate with the number of rib fracture. And it's been estimated that someone who has more than rib fractures, they generally have more risk of mortality. Why rib fracture is clinically important? In the presence of rib fracture, is basically it's indicate the severity of chest trauma. So when you have rib fracture, it will make you have other injuries, including lung, other organs. But at the same time, it will lead to significant morbidity and mortality of the patient and length of stay in the hospital, as well as a prolonged recovery. But it's worth to mention that someone who are older, they have poor physiological reserve, poor respiratory reserve, and having multiple rib fracture, it will make them really compromised much quicker than someone who much fit and healthy. And it's more important to mention is having pain from rib fracture sometimes is even more harmful than the pathology itself, the injury itself. Because pain directly leads to inability to cough and breathe deeply. It will make you having sputum retention, atelectasis, reductions in your FRC, which is functional residual capacity. It will compromise your lung, and also it will lead you to VQ mismatch and ventilation perfusion mismatch, hypoxia, and respiratory failure. And we often see being contacted very often by the nurses, our outreach teams, to admit patients to hospital. They've been forgotten on the wards a few days and they've been okay, and suddenly they deteriorate. It's just because it's one things lead to another. What we need to remember is there are certain areas of fractures that can be indicating the severity of injury. And I always want to remind you that someone who comes with fractures of the first and the second rib, you really need to think it's really significant injury. Particularly these patients, these are particularly protected fractures. So it must lead to high velocity injury and usually associated with vascular injuries. 5 to 9 rib fractures usually associated with pulmonary complications such as pneumothorax and hemothorax. And also the lower rib fractures, they are floated ribs mostly. And their injuries sometimes associated with organ injury, but you need to realize also it does take a significant impact to fracture these ribs. So the enhanced recovery for rib fractures, essentially, it's a term we tend to use with these patients, which is generally, we need to have a team approach to managing these patients. We need to have an early referral pathway and risk stratification. We need to facilitate early mobilization for these patients, which is very, very important, and self-care. Optimize analgesia, avoid excessive opioids, and also use adjuncts such as NSAID, which is works best, but you always have to remember, if your patient is old and is above 70, you have to be always careful with renal injury with these patients. And usually I don't prescribe NSAID for elderly patients. Early use of regional anesthesia and more recently surgical stabilization of fracture has been very topical. So rib fracture scoring system, basically, it has been internationally, basically, there's increasing number of internationally scoring system available, but they are not usually universally accepted. There is a rib fracture scoring system, which is basically based on a mathematical calculations, the number of rib fracture by the number of the site, including the age of the patient. And you'll get a scoring between 3 and above 15. And if someone's basically above 15, it stratify you to how urgently you manage these patients. And someone's between 3 and 6 may need conservative management. But this is a very poor, it's not been very good indicator for respiratory morbidity and mortality. And also we have chest trauma scoring system. So someone who has a chest trauma scoring system above 5, which will might indicate that you are increased mortality and pneumonia, and obviously death in the complication in the first 24 hours. There's RIP scoring system, that's a radiographic score. More recently, it's been realized that increasing age, number of rib fractures and pre-existing chronic lung disease, and also use of anticoagulations before the injury and oxygen saturation at presentation does have an impact how you stratify these patients. And that's a group of anesthetists from Plymouth. They come across with, they made a stumble scoring system. Essentially, it's also, this is scoring systems used to prognosticate how early you will manage these patients and stratify them. So if you have a score, it's divide the scoring between to mild, to moderate, to severe, and mild is 1 to 10, and severe is 11 to 30. And if you have above 30, essentially, or risk, high risk. And looking at this, so if you have a score of 1 of 10, you generally use conservative management, simple analgesics. But if you have a score of 11, 30, which is quite a wide range, you'll use the same analgesic, standard analgesic drugs that you use, but at the same time, you will combine them with other analgesic techniques, such as regional techniques. And you have severe, which are above 30, then you will probably, these patients, they require intensive care units or surgical techniques to stratify them. In our health board, we generally use refractor pathway. We just introduced that one. We identify the patients quite early from A&E. As they come through the emergency department, we basically identify them, and essentially they started on analgesic management right early at the beginning before they go to the ward. And once they landed to the ward, it will be basically multidisciplinary teams involved in managing these patients, including physio, outreach nurses, and also medical teams who's looking after them, or surgical team. And they will be risk stratified as we have a look at the stratification of them. And also this is combined with their severity of their level of pain, usually classified into 3 groups of patients. Either we manage them as a level 1 or level 2 or level 3. You can see from level 1 generally just analgesics. In level 2, we advocate using regional techniques, but also at level 2, when they reach that stage, we involve more the intensive care colleagues and outreach to be observed more closely. When they reach level 3, it means they are more compromised. They might need to have intensive care, but that's mean also they need to be observed more closely. Moving on from here, the general analgesic drugs that we use for analgesic refractor, we use strong opioids, but generally we can use tapentadol and tramadol, NSAID and COX-2, paracetamol and gabapentinoid. There are other drugs that we can combine with these general medication. But I know that we have talked a lot about medical management for general surgery, but opioids generally that what we use for refractor, it's generally better for pain at rest, but it's not for activity. And it does have side effects of sedation and respiratory depression, nausea, vomiting, ALS, urinary retention. It does make you have abnormal sleep. And some people, they will develop opioid-induced hyperalgesia. Not to mention IV-PCA, it makes you bound to, to the bed when you, basically these patients, you advocate early mobility with them. When you stick them to a morphine PCA, they won't be able to move and do their physios. So it's indicated in severe pain and when regional technique is contraindicated, and PCA is not suitable for unconscious patient, as is patient-controlled analgesia. Regional techniques, there are a number of regional techniques has been recently evolving in managing refractures. And we can see intercostal, paravertebral, thoracic, facial plane blocks, epidural, and interpleural blocks. Speaking about individual techniques, I mean, for example, epidural, it's one of the quite oldest technique and still a gold standard in managing analgesia. But we have noticed recently the popularity of this technique has come down more and more. We're less doing epidurals for managing a refracture. And this is particularly because the first emerging of the new regional techniques, and also with basically type of patient that we get, they are complex, they have so much other comorbidities that they can be contraindicated. And besides, when you put an epidural, it does give you motor and sensory nerve blocks, which doesn't allow the patient to move out of the bed and do the mobilizing them easily. So, and it does have also side effects of hypotension, which is being noticed in about 19 to 20% of these patients. So, not to mention, that can be quite risky. And with these patients, they might have other injuries also. So it's not as popular, but it's still quite good analgesic technique. And we do sometimes provide if the other analgesic technique has failed. Intercostal nerve blocks, it is quite effective, and it's involved putting local anesthetic just in the neurovascular vascular bundle, just under the rib itself. With the use of ultrasound, it's become much easier and more effective. It does provide about 12 to 18 hours of analgesia. However, it does have limitations. We can't do single injections to every rib. Maybe 1 or 2 ribs you can do intercostal nerve blocks, and you can't leave a catheter for these patients. So it does have its limitation, but it's quite effective. Perversible blocks, again, it is relatively not been known for a long time. It does cause unilateral sensory motor and sympathetic block because you're putting local anesthetic right in the paravertebral space with basically the anterior rami of the spinal nerve is there and the sympathetic chain is there. You would be able to insert a catheter and you can leave it for a longer term. The spread of local anesthetic, you can get few levels above and below, although that has been recently been questioned. It's difficult technique to master by some people. There's about 6 to 12% of failure rates, particularly with people who might have significant thoracic injuries, having surgical emphysema and hemopneumothorax. Visualization under ultrasound can be technically difficult. There is this increased risk of nerve injury, and pneumothorax particularly can be blind when you look at with the ultrasound. So as you can see from the image there, you can see the transverse process, and you can see the pleura underneath, and also you can see the basically the muscle in the back and the costal transverse ligament here. We just penetrate the costal transverse ligament and you put local anesthetics in there. If I show you this video, it basically does explain it a bit better when you do it under ultrasound guidance. So you can see this is the transverse process very clearly, and he's bringing the needle through the costal muscles, and then he's piercing the costal transverse ligament there. And as he piercing the costal transverse ligaments, you put local anesthetics, and you can see the pleura, the parietal pleura is pushed down. Serratus anterior plain block, again, this is recently has been popular in managing refracture. It is a chunky muscle in the anterior lateral part of the chest wall. It is quite extensive, and by putting local anesthetics under the serratus anterior muscle, you generally block the lateral cutaneous branches of the spinal nerve. So essentially, it's still speculated how does it work for refracture. We all know local anesthetics can diffuse through the tissues, and it can pretty much diffuse through different pores and porous spaces in that area where neurovascular bundles go through, and that's why probably it will give analgesia for refracture. Essentially, it was first described in 2013 by Blanco. He's an Italian anesthetist. He was in the UK. He's in Dubai, and he's earning a lot of money at the moment. He's essentially putting local anesthetic just, if you can see the rib there, you can just put local anesthetic just under this, over the rib, and you can see the local anesthetic spread. Usually we do it at the anterior lateral part of the chest wall at T4, fourth rib, And once you put local anesthetic, you can see the area spread, open up, and you can leave a catheter. It's quite useful for certain type of patients. The risks are small if you do it under ultrasound guided. The beauty about this block, most A&E doctors can do it simply. Erector spine block, this is quite recent block that is being developed. It's been described in 2016. It's a group of muscle, usually is basically on the lateral to the spine. Usually you can think of them, they are paired of elliptical cylinder. And erector spine itself, the block itself, is basically a paraspinal interfacial plane block. And when you put the local anesthetics anterior to the erector spine, you block the dorsal rami. And when you put the local anesthetics, it's been noticed that the local anesthetics can spread anteriorly into the paravertebral space area, where it can block the anterior spinal nerve, and also can spread to the sympathetic chain as well. There are a lot of cadaveric studies and dye studies that has demonstrated that, but it is speculated that is the mechanism of action of this block is it does work on a different level. The good things about erector spine, when you put the local anesthetics, it does have a very good cephalocodal spread. So it can spread all the way up from the top of the neck, from the bottom of the neck, all the way down to T12. And it has a very good safety profile. We have started doing erector spine block for most of our refractors, particularly we see the type of patient we have. The block, the scanning is very easy, and generally there are different techniques has been described. Personally, if you can see the image before you, you can see the ribs, they are round. And as you scan the ribs and you move laterally, basically you can identify the transverse process when they become squared shape. And you can see the erector spine muscle sitting on them. And you put local anesthetic just under the erector spine muscle and at that level. And that should be sufficient. You should get a typical linear spread of the local anesthetics. I can show you this video. Essentially, this is showing that he's putting a needle. He's putting a needle there, and you can see he's touching the transverse process, and he's piercing the erector spine muscle. And he's putting some local anesthetic in there, and you can see the local anesthetics has just spread into the muscle, but it's not quite right. So he's walk off the transverse process. And as you put the local in there, you can see a nice linear spread. And this is what you need to see when you do this block. So why should we use erector spine block? It's very, to our experience, it's very effective. I think because of the limitation of the time that I had today, I could have included the project that we did, and we presented the Wales Pain Society. Essentially, we had about 20 patients we had inserted erector spine block, and we have noticed is actually significant, above 50% reduction of opioid requirements following doing the block for these refractors, and they have very good satisfaction as well. It is safe. You don't need to go into the basically neural plane or close to the spinal cord or any major plane. It's basically a facial plane. It's less invasive. It has a low complication rate, low failure rate, emergency, and it can be used for emergency and elective procedure. And also, most importantly, those patients who can be on anticoagulation and risk of bleeding, they can be used as well. So I have done it on patients who's been on significant amount of anticoagulation, or they have very low platelets. As long as someone who's experienced and knew what he's doing, I would say it's quite safe. There was a couple of case reports that's been reported about pneumothorax, But I would say we haven't had any single complication so far in our health board. Since the Erector spine block has been described, there was a vast number of application has been applied, and you can you can go through the list. So which block to choose for refractor? And this is something always come to an experienced hand when you come and you decide. And you need to assess the patient, obviously, and you need to know your anatomy about the supply of the chest wall. But generally, I come up with this table, and I think it's very useful. For those who are anterior lateral refracture, generally Serratus anterior plane blocks works very well. For posterior lateral fractures on your lateral, you might be able to do Erector spine or Serratus or paravertebral. Bilateral refractures, we can do epidural, bilateral paravertebral or bilateral Erector spiny and or Serratus plane block. I want to touch on surgical stabilizations for refractor. This is topics has increasingly been described nowadays with the evolutions of or development of basically major trauma centers. Now we see more complex trauma patients, and it has been suggested those patients who are significant chest injuries, they would be considered for this. Usually done by orthopedic surgeon who deliver the service. It's not necessarily to fix all fractures. Usually 4 to 9 ribs, they generate the most pain as they provide the majority of the stability of the chest. I have just put down broad indication, but there is Rib Fracture Summit that is basically a whole society that's just talking about rib fracture. The guidelines can be variable from one major trauma center to other, but what we generally accepted that is chest wall, someone who has chest wall instability with significant displaced rib fracture. If they have 3 ipsilateral, severely displaced, or failure to wean ventilation, usually we indicate doing this refixation. And you can see they're using generally different devices, but mostly they are titaniums. In summary, management of refractor, it's multidisciplinary: early physiotherapy, early mobilization, early ICU involvements if they deteriorate. Multimodal analgesia, early intervention, regional anesthesia to reduce risk of complication. And there is growing evidence that regional anesthesia will improve ventilation and reduce pulmonary complication and mortality. Epidural analgesia, it's superior to systemic opioid therapy, but there was no evidence that it showed it's more superior than other regional techniques. And thank you.
Well, thank you very much, Wanj. That's a very pleasant presentation and very informative as well, as usual. If I may ask one question, how long can you keep the catheter in those patients?
So generally, we advocate leaving the catheter for 5 days. We do have situations where the patients, for a number of reasons, they can't tolerate other medication or they require the catheter to stay a bit longer. We have kept the catheter up to 9 days, but that's require regular reviewing on a daily basis. As I said, if you depend what, for erector spiny, we do tend to leave, for facial plane catheter, you tend to leave them, you can leave them longer. But for epidural and paravertebral, generally it's advocated not to leave it very long.
Yeah. Now, Wanj, if a colleague from Iraq asking you how to organize or set up a surface for rib fractures in one of the hospitals, what are the main elements that you need to apply to have a successful surface there?
So I think to set up a service for a refracture, you need to find out how many patients you get that's required. And based on that one, you generally talk to the people who are involved in the care of these patients. So you start from A&E and to the intensive care department, and also anesthetics, or the team who's actually involved in taking care of the patients. The setup is generally, once you have identified the needs, you generally decide what is the best for these type of patients, depend what is suitable and what arrangement they have. And what we have noticed in our health board, we used to manage refractors very badly. They used to have a lot of complication and a lot of intensive care, and we have identified this by auditing these patients. And we realized that there was a gap in the care of these patients. So we basically provided that gap, and we basically supported it. And that's why we come up with this pathway, as you can see.
Yeah, thank you, Anj. Anj, just touching on the on your patients, how early do you get those patients referred to you to have a block like serratus, or I mean spinal block, erector spinal block?
So at the moment, we do get relatively quite early involvement, because we do get a referral to the acute pain team, who they basically assess the patient. And we have the scoring system, as I showed in my slide.
Yeah.
If the patient is high risk because of the comorbidities exist in there, because of their age, lung comorbidities, they have anticoagulation they can't tolerate, or even if they are in a lot of pain, we tend to be identified by the on-call team that the patient require a regional technique. And essentially we do the blocks for them in theater. So we don't do single block, we do a catheter technique, essentially. The service, it's not 24-hour at the moment, but we are looking at training everybody to provide the service at 24-hour basis. So essentially the patient cannot get delayed.
Yeah. Thank you very much, Manj. That's great presentation, and thank you for answering questions. I think with this we end our conference. Unfortunately, Dr. Arkan Ahmed is not available because he has unfortunately his mother passed away, so he won't not be able to present. I would like to thank you all for taking part into this conference, and we are all looking forward for future events and activities in collaboration with the societies from Iraq. And on behalf of the United Iraqi Medical Association in UK and Ireland, I would like to thank you all for your time, and I hope you enjoyed the conference and you have benefited from the information that's presented. And a special thank for our speakers, Dr. Ala Al-Tai, Dr. Abdul Hamid Dabbagh, Dr. Nawfal Al-Mubarak, Dr. Ali Aziz, Dr. Khalil Ahmed, Dr. Hisham Al-Shadar, Dr. Wanj Al-Khafaf, and our trainees, Dr. Muhammad Wahab and Dr. Sindus Adnan Jawad, and for our moderator, Dr. Ayad Abbas Salman, and our chairs, Dr. Rafid Aziz and Dr. Mahsen Rikabi, and our admin, Dr. Noor Aziz. Thank you all, and I hope to see you again in the near future. Thank you very much.
Thank you.
يمكن دقيقة واحدة مؤيد.
Dr. Rafid Aziz, yes please.
Oh, thank you. وكان شكري للجميع على حضوركم. أنا آسف غبت عنكم يمكن ساعتين لأن كان عندي شغل وكلش بزيد تعرفون باليوكي. شكر جزيل لكم جميعا. شفت اسماء عديدة من الأصدقاء والأساتذة. استاذتنا دكتورة فضيلة راوي أيضا مشاركة ويانا. شفت اسمها الآن. أهلا وسهلا بك دكتورة فضيلة. نتمنى إن شاء الله الصحة والعافية، ونشوفك إن شاء الله في مؤتمرات قادمة. مثل ما ذكرت يوم أمس، يعني المؤتمرات إن شاء الله راح تكثر. الجمعية هذه السنة إن شاء الله أكثر من السنة السابقة، إن شاء الله تكون سنة أجمل هذه السنة. مثل ما ذكرت اكو الفورم اللي موجودة اللي ممكن تخلون بها الفيدباك مفيدة جدا لنا، ممكن تذكروا أسماءكم حتى نرسل لكم السيرتيفيكيتس. كذلك إذا عندكم أي فيدباك لأي شيء تحبون للمستقبل للجمعية إحنا نرحب به أيضا وممكن نعمل به أيضا. هدفنا هو خدمة أطباء العراق، وليس فقط أطباء العراق، يعني أطباء الأسنان والصيادلة وكذلك الكادر التمريض والكادر الصحي. هدفنا هو شلون نرفع المستوى الطبي والصحي في العراق، وهدفنا أنه شلون نرفع المستوى الصحي للبلد بصورة عامة والتعليم الطبي أيضا. الطريق صعب، لكن احنا نقول even we start with small projects with a big impact, hopefully that will help. كما تعرفون يعني المعوقات كبيرة جدا في العراق، لكن احنا نحاول جهدنا انه نتجاوز هذه المعوقات بوجودكم ان شاء الله ومشاركتكم واسنادكم لنا. وشكرا جزيلا، اتمنى لكم امسيه سعيده، وان شاء الله نلتقيكم في مؤتمرات قادمه قريبا جدا ان شاء الله. تحياتي وسلام للجميع.
دكتور رافد 1 minute if you don't mind.
نعم تفضل دكتور علاء، تفضل.
حبيبي تفضل.
جزيل الشكر لكم حقيقة ولكل الأخوان، فالجهد كبير البارحة واليوم، ويعني الشكر مقدم لكم قبل ما يقدم الشكر لنا، ونتمنى أنه نشوفكم عن القريب فيس تو فيس وتنتهي هاي الأزمة، وأتمنى الصحة والسلامة
دكتور علاء أنت ميوت يمكن.
لا
يور مايك از ميوت.
شكرا.
شكرا جزيلا دكتور علاء، بارك الله بك. شكرا بالاخوان جميعا. اذا اي حب. نعم دكتوره فضيله تفضلي.
جدا سعيده ومتشكره.
احنا اسعد
لوجودك وكل
استاذتنا العزيزه، انت شكرا جزيلا على مشاركتك اليوم.
الله يخليك.
جدا فرحت من شفت اسمك مع الحاضرين.
الله يخليك وفتحة وجه كلكم رفعت راس.
وان شاء الله تقدمي لنا محاضرتك عن الاوتيزم ان شاء الله في المؤتمر القادم عن طب الاطفال قريبا جدا ان شاء الله.
ان شاء الله، وان شاء الله قريبا راح نعطي محاضره عن الاي دي اتش دي اولسو.
شكرا جزيلا، ان شاء الله شاكينا مؤتمر عن طب الاطفال قريبا.
حاضره لاي شيء تحبوه.
شكرا دكتورتنا العزيزه واستاذتنا العزيزه، الله يبارك فيك. شكرا جزيلا. شكرا. اعتقد دكتور مي ذكر ايضا وانا ذكرت امس انه مؤتمرات قادمه راح تشمل قسم منها على برزنتيشن للاطباء المتدربين، راح نسوي مؤتمر خاص لهم. هناك ايضا مؤتمر للطب النفسي، مؤتمر للطب الباطني، ومؤتمر طب الاطفال، ومؤتمرات اخرى في اختصاصات مختلفه. كذلك راح نستمر هذه السنه في حمله الجمعيه للتعليم الطبي العالمي في مشاركة كليات طب من بريطانيا وكليات طب من العراق إن شاء الله، ويشمل أنه الخريجين الجدد مع طلاب السنوات الأخيرة في كليات الطب. مشروع فينيكس إن شاء الله أيضا راح نركز به على دعم كليات الطب، ومن خلال عملنا مع جامعة كارديف، كلية طب كارديف إن شاء الله، وهذا راح نعلن إن شاء الله قريبا جدا. إذا أي أحد عنده سؤال أو أي مداخلة إحنا نرحب بكم. أقصد سؤال للجمعية يعني أو عمل الجمعية. نشكركم أيضا شكرا جزيلا.
بنثمنها للجمعية دائما.
السلام عليكم. السلام عليكم. السلام عليكم.
عليكم السلام. تفضل أخي.
السلام عليكم. Thank you very much for this lovely conference. Really, I am Dr. Talal al-Borda Chief from Iraq. And I was a student and the Arab Board certificate, and my greeting to all my professors and my colleagues. And I just want one question, please. Where is the center of this association, of the Iraqi Association for Anesthesia? Where is the place, the building, I mean?
Okay, unfortunately we don't have building. I mean احنا على قد حالنا بهالاشياء، احنا متطوعين. الجمعية مسجلة كجمعية ومسجلة كشركة في بريطانيا، لكن كبناية احنا ما عندنا بناية، ما نملك بناية. يعني احنا نستخدم مثل قاعات في مستشفيات لندن أو مستشفيات خارج لندن، والعمل هو عمل تطوعي في وقتنا الخاص ومن جيبنا الخاص.
من تبدون تدفعون اشتراكات او نشتري بدايه، ما عندنا مشكله.
ان شاء الله. طبعا الانتماء مفتوح لكل الاطباء العراقيين وذوي المهن الطبيه والصحيه ايضا. شكرا جزيلا لكم. اعتقد ناتي الى نهايه مؤتمرنا هذا. مؤتمر كان رائع جدا، ابتدينا به سنه ان شاء الله تكون سنه سعيده بنجاح مؤتمر جيد جدا، وان شاء الله مؤتمرات الاخرى تكون في نفس المستوى وان شاء الله افضل، ونلقاكم ان شاء الله وجها لوجه في مستقبل قريب ان شاء الله. تحياتي للجميع، اتمنى لكم الصحه والعافيه.
شكرا جزيلا دكتور، شكرا جزيلا للجميع.
شكرا جزيلا للجميع.
شكرا لكم.
شكرا جزيلا.
شكرا، مع السلامه.